right arrow or click through.
Hi, everyone. I first just want to say I can't say enough how lucky we are to have the program that Felicia and her team has developed with regard to providing additional care and support for patients and families. And it really is unique to the Penn Memory Center that we offer those kinds of services. I think if you are seen in other locations, mostly because of financial constraints, there's not that kind of support and programming. And so, and I think they've done an incredible job of creatively developing these programs. So very grateful as a clinician to have their support. I'm Dave Wolk. For those of you who don't know me, I co-direct the Memory Center with Jason. We've been doing this team for a while now. And I also direct the Alzheimer's Disease Research Center. So it is incredibly gratifying and actually humbling to see so many of you here today. I mean, it's amazing that we have this kind of a turnout. And while there's a long road ahead for us within studying and treating and caring for patients with Alzheimer's disease and other conditions like it, I do hope that you all at least feel some connection to the idea that I think we are entering a new era in this disease. And my hope is that this is going to be very much like the beginning days of where cancer started to get a real foothold on treatments, where now there's an explosion of therapies in that field that's really targeted towards individuals and their individual diseases. And so while, again, I think we acknowledge, and I think it's important to know that there's a tremendous amount of work ahead, this, to me, is a real inflection point in the field. And so that's why I entitled this A New Era. I could have entitled it A New Hope, but then I feel like there'd be copyright issues with the Lucasfilms people. So, Sanjeev did a wonderful job on touching on some of these. I'll sort of reinforce or amplify some of the things that he talked about earlier. But I think over the last 5 years or so, there have been several things that are really kind of earth-shifting within our field. One is, and this has been known for a while, but I think somewhat simplified, in that there really is a recognition and truly now an embrace of the idea that Alzheimer's disease is a heterogeneous condition. I think in the past we've thought of it as a more kind of monolithic, unified type of process, and it limits our ability to treat the disease because there's lots of different biology and factors that go into Alzheimer's disease. And I think the field has accepted this fact about the disease. It makes it more complicated, but it also allows us to develop tools to better treat it. Another, I think, major change, and we'll talk about in a little bit, is that how we even diagnose the disease, at least in a research setting, and I definitely think within clinical practice in the very, very near future, we're starting to define the disease based on its biology rather than what a clinician says about someone's likely underlying diagnosis. As Sanjeev mentioned earlier, another major thing, something that I can't tell you all how skeptical we all were as a field that we would ever have blood tests for Alzheimer's disease. Several years ago, it was unheard of to think about it. There have been lots of attempts, but to get measures from proteins in the brain into your blood that you can detect is, I think, an amazing accomplishment within the field, and will change not only how we treat the disease here, but it has implications for our ability to treat the disease across the world. Because a lot of the things that we talk about that we do in research and starting to emerge in practice here in this country are just not things that are accessible to other countries, and certainly to other areas of the country outside of big cities like our own. Another advance that, again, Sanjeev talked about, I'll talk a little bit more, is while these drugs are imperfect, by absolutely any measure. They do seem to be slowing down the course of Alzheimer's disease. We do seem to actually be able to change the biology of the disease. And that, again, I can't tell you, I've been doing this a little bit longer than Sanjeev, although not that much longer. He just looks a lot younger than me. The thought of a drug that really is targeting the biology of the disease and has an effect on patients' lives is something that, again, we've been working on for over 20 years with very little, with many successes in the laboratory, but never any successes in patients until recently. And so that's, I think, an incredible change. And I think all of this together brings together an era of precision medicine. And what that really means is where we target therapies and drugs that are tailored to individual patients based on understanding their biology, all the factors that go into why they have the symptoms that they do. And I think we will start to integrate that into our practices again in the very near future. And I think I've talked about this several years ago, maybe at the last time we all met together, and there it was more of a pipe dream. Now I think it's a reality that we're heading into. So I do always like to tell people who we are, because I think there's always a little bit of confusion what the Penn Memory Center is, what the Alzheimer's Disease Research Center is. And on some level, that probably doesn't matter all that much, but I think it can be confusing to people. But our Memory Center really is a center that is focused around clinical care, so it's where we see patients. It engages in clinical research, and then it really is involved in education and training, education of the community, but also training of new clinicians, as Felicia mentioned earlier, within the social work sphere, but certainly within neuropsychology and within neurology and geriatrics. And the reality is we have such a small number of clinicians for a condition that is a major, major public health issue. And so it would be wrong of us not to make training a major aspect of what we do, because we just don't have enough clinicians to take care of patients. And it's why you all who've tried to get appointments with us have the pleasure of hearing about 6-month wait times or longer. The Alzheimer's Center is actually a National Institutes of Health funded center that really is to serve as the nidus or the center of Alzheimer's disease research at Penn. And it's very closely integrated with the Penn Memory Center, particularly with regard to all the aspects of patient-facing work. But there's lots of other work that goes on in the Alzheimer's Disease Center in laboratories and in other areas of research that you might not see, but that are working diligently with materials and data and blood and spinal fluid and imaging that we get from all of you who participate in our studies. I just put this in because I just like pictures of myself and figured it would make me feel good to be able to show another image of myself. So the team, we've already mentioned Jason, and Felicia serves as our executive director. Actually, I think I put this in because PowerPoint made this slide for me automatically, and I was like, that's kind of cool. I like those. So. Our clinical core of the Alzheimer's Center, but also the Memory Center, really involves a number of physicians, and we've grown dramatically. I think when Jason and I and Felicia were doing this 7 or 8 years ago, there were 3 clinicians and 1 social worker, which was Felicia, and now it's grown dramatically over the years. We have 8 or 9 clinicians. We're continuing to get more clinicians who are coming through our training program, and we like to keep people who come through our training program, which Sanjeev has led for a number of years. And so the hope is we will continue to grow to be able to meet the demands of our patients. Just to give you also an idea of the Alzheimer's Disease Research Center, this is there's more pictures of me. See, there's me again. The Alzheimer's Center involves actually leadership in a variety of disciplines here at Penn. And so it includes the clinical core, which I, with Dawn McCannick-Hamilton, lead, and it includes outreach and engagement core, which Jason leads with Emily Largent. But there's also other cores that are involved in genomic studies, in blood biofluid biomarkers, in neuroimaging, in data management and informatics, AI type of work. And so there's a lot going on at the center, again, that I think all of you probably don't realize how much your data and information you're providing to us is really pushing the field forward, and all these individuals' work is dependent on your participation. So I'm going to talk a little bit about some of these sort of changes that have occurred in the field, and I've given this slide before, but I just, for emphasis, Alzheimer's disease is heterogeneous. I think everyone in the room could agree about this if you've talked to other families that are dealing with it. It's heterogeneous in age of onset. Usually we think of people in their 70s and 80s with this condition. We see people in their 40s and 50s with this condition. The rate of progression is very variable. Some people, will be 16, 17 years and you'll see very slow change. Other people in just a couple years will have really significant change in their thinking. The pattern of the pathology in the disease, which we'll talk a little bit about, also is different. Some people, memory areas of the brain are most affected. That's what we think about with Alzheimer's. Sometimes it's visual spatial areas, though. Sometimes it's language areas. And so that's heterogeneous. Why is that heterogeneous? Hard to know. There are co-pathologies that go on in Alzheimer's disease. That, again, is something we as a field have been really learning a lot about in recent years, and Penn has really led the way in this. So vascular disease often is combined with Alzheimer's disease, but there are other degenerative conditions that can co-occur. Other medical conditions influence it. The cognitive and behavioral symptoms are different because of all these differences between individuals. So again, someone might have more memory problems. Someone might have more behavioral problems. They might have more agitation or hallucinations or depression. And so that can vary across people. And then I think importantly, and this is something I think we can leverage, is there are differences in how resilient or vulnerable people are to the disease. The same amount of Alzheimer's disease in two people can look very, very different. Some people can tolerate a lot more of it before even having symptoms, and other people are very vulnerable to it. And so we need to learn why that's the case so that we can better enhance people's resilience to it, so you can live longer even if you develop some of the pathology without having the symptoms affect you as much. And I think really related to that, and this is something we study quite a bit here, are what we call social and structural determinants of health, things like education, stress, access to health care. And these are things that may influence in particular why underrepresented groups in research often deal more with these kinds of medical conditions, and in particular with Alzheimer's disease. And so I put this in. This is from work we did and published a few years ago. Not to confuse you all, but these are called spaghetti plots, and not having eaten yet, they're making me hungry, I think, a little bit. But basically what each of these lines are individuals and their trajectory on a cognitive measure over time in people with what we call preclinical Alzheimer's disease, where they have evidence of amyloid in their brain, but they don't yet have symptoms, and then people with mild cognitive impairment. And if you look at their trajectory over time, going down is worse. And a lot of people do go down, and overall the dotted lines are the average, and they slightly go down. But there's incredible noise. Some people get a little better, some people get a little worse. It's just a very noisy condition over time, and the testing itself is relatively noisy as well. But again, I think this marks the heterogeneity. There are some people who have dramatic declines over this is a 2-year time frame, and others, again, that don't change at all, or even sort of do a little bit better on our tests. And so one of the things we've worked on is, are there better biological markers we can use that track the disease as opposed to these kind of cognitive tests? And so we've been measuring the very earliest parts of the brain that are affected by Alzheimer's with MRI scans. This is the part of your brain involved in memory, and we at really fine levels can measure it. And if we do, we really improve. That dotted line now has a bit more of a downward trajectory, so we're better tracking the disease over time. But I think the bigger point is even with this biological measure of brain shrinkage over time, which now most cases go down, they go down at very different rates in people. Some people it's really fast, and some people it's much, much, much slower. And so heterogeneity is very much a part of this disease. Even in a group that we really selected, you're very mild and you have Alzheimer's disease, even with that very selected group, there's an incredible amount of heterogeneity. The one thing I'll point out, though, is these kinds of measures have influence on how we do trials. So if you use that cognitive measure, it would take about 1,700 people to do a trial to show a 25 to 50% effect of a drug, whereas if we use our imaging measure, you could do the trial with 114 people. And so that kind of thing actually helps speed along the field and for us to develop better therapies. Another source of variability is likely genetics. And as Sanjeev mentioned, there used to be these sort of 3 genes that were associated with what's called an autosomal dominant form of the disease, which is very, very rare. But then there was this one risk gene called apolipoprotein E that many of you have probably heard about that increases your risk of the disease. And that was it. And then over the last 10 to 15 years, really the last 10 years, many genes have been discovered and many genetic risk factors have been discovered. Almost 80 genetic risk factors have been discovered in the last 5 or 6 years. And I will say a lot of that work comes from Penn. So a lot of that work comes from genetics that all of you, or those of you who provide that for us, go to, but also Penn is the center site of what's called the National Institute on Aging's Genetic Consortium. And Lisan Wang and Jerry Schellenberg, who are in our ADRC, lead that across the nation. And so we've really, Penn played a big role in the genetics. The bottom line is, though, that knowing the genetics more, and many of these genes, they give you a little bit more risk, of getting it, or if you don't have it, a little less risk. So it's more how they add up together than any individual one. But they also help us understand targets for the disease. So the genes are telling us that they're associated with things like inflammation in the brain, so microglia, which are the inflammatory cells in the brain. A lot of the genes are linked to that. Another area they're linked to is lipid metabolism. And so cholesterol and other aspects of lipid function are important. And so by knowing the vast genetics of this disease, and it's going to be heterogeneous, some people are going to have more of one type and more of the other type, we're starting to learn the biology of the disease and becoming better able to treat it. One other, I think, really important thing, and this gets a little complicated, so I'll try to make it simple, is Alzheimer's disease occurs in a person who's lived a life. And our brains age. And our brains actually age at different rates, and there are different changes that occur to our brain, just like aspects of our muscle strength and our joint strength changes. Our brains change sort of dissociated from Alzheimer's disease, just part of normal brain aging. And actually, remarkably, using, and this is from work that we did, using machine learning, or AI, one can actually predict someone's age, kind of like the old carnival people used to do, with a brain scan within about 5 years of what your actual age is. And so we can say, you look like a 70-year-old brain, you look like a 65-year-old brain, and do that pretty accurately. However, we're not always 100% accurate. So there are some people who look like their brain looks older than they actually are. And there's some people who their brains look younger than they actually are. And it turns out we can separate that brain age effect from the effect of Alzheimer's. And when we do that, we see that they both contribute to cognitive problems. So in other words, if you had a healthier brain with the same amount of Alzheimer's disease, or your brain ages better, you'll actually have less symptoms, whereas someone whose brain is aging faster will have more symptoms with a given level. So why is that important? Because there are probably a lot of lifestyle factors and other things that go into resilient brain aging and might allow one to have less symptoms of the disease. And in fact, there now is a lot of data about lifestyle factors that reduce your risk of the disease, probably by making your brain more resilient. And it turns out in a number of studies that about 40-50% of the risk of Alzheimer's, not genetics, is related to these lifestyle factors, things like exercise, eating well, lipids and vascular risk factors, education, a variety of those kinds of things, obesity. Those factors do increase your risk of, I think, less resilient brain aging, and then therefore more likely to develop symptoms of Alzheimer's disease earlier, again, for a given level of Alzheimer's. So these, I think, this slide can be actually kind of comforting in that there are things we can do to make our brains as resilient as possible to this condition. One thing, again, that I think has become really evident and something that we're really pursuing is it does turn out that different groups, particularly groups that are less well represented in research, as Sanjeev mentioned earlier, seem to have higher rates of dementia and Alzheimer's disease. And this includes the African American or Black community, and this includes the Hispanic or Latinx community as well. And they both show about a doubling or a 1.5 rate of developing dementia. And so why is that the case? And we believe, and there's, I think, more and more data to support this, and this gets back into that brain aging and resilient brain aging, that a lot of this has to do with things like social and structural determinants of health, which are the challenges and opportunities people have, access to health care, other life stressors that influence how your brain ages, and that those things are, again, important things for us to learn about so we can intervene earlier with, not just, I think, on an individual level, but even on a policy level to push forward. And that's why many of you in this room have been getting these requests to fill out information about social and structural determinants of health, things like where your neighborhood environment, your early childhood experiences, education, life stressors, socioeconomic status. And this actually just graphically shows what we ask people about. We ask people about childhood adversity, discrimination, health literacy, et cetera. And we're really trying to learn the degree to which these different factors influence how people do with this condition. And I think it's really important work, again, for helping us to move the field forward and more equitably take care of our patients. Our ADRC, as you know, is very committed to improving representation in aging and AD research. And as Sanjeev said earlier, the Alzheimer's Disease Neuroimaging Initiative, that's the one with the ADNI 1, ADNI 2, ADNI 3, ADNI 4, ADNI Go. It's like Rocky and Creed at this point, that it's like so many sequels. The last Creed was really good, by the way, if anyone saw that. Really enjoyed that. Those studies had incredibly poor representation of Black participants, only about 5%. And so much of what we know about biomarkers has come from that study, and that's a problem. And so we're trying to address that in part through the Aging Brain Cohort dedicated to diversity. I think I would say that this is not something we're doing alone. This is a national effort, and the NIH is very, very much engaged in this as well. And so I think it's hopefully a changing time in that regard. And in reality, it's more than just even understanding the disease in people across different groups. It's also just an equity issue. Everyone should be, involved in research if they want to be. Moving back to other aspects of heterogeneity in the disease, one of the things that's been really discovered over recent years, again, I think we knew this for years, but we kind of didn't accept it, was that Alzheimer's disease is often associated with more than one pathology. And so this is from the Rush University data set, and these are people who clinically got a diagnosis of Alzheimer's disease, and then this was their pathology. So these are people who donated their brains for research. The non-blue groups here all represent misdiagnosis, where they were told they had Alzheimer's disease, but they turned out to have a different degenerative condition or vascular disease. And so it was about 20% of the people. And if you look across studies, it's about 20 to 30% of people are mislabeled as Alzheimer's when they have a different degenerative condition. It's not because the clinicians are bad, it's just because it's really hard to diagnose the disease purely in a clinical manner based on paper and pencil tests in individuals. So that's one issue. The other is if you look across the blues, those are all people who they did indeed have Alzheimer's disease. Most of them had Alzheimer's disease with vascular disease or Alzheimer's disease with another degenerative condition. And in fact, the majority of them had both vascular disease and other degenerative conditions in addition to Alzheimer's. And the smallest group with Alzheimer's disease was people with just Alzheimer's disease. So the least common form of Alzheimer's disease is Alzheimer's disease alone, just a sliver. We here, so people who participate in the ABC study and other studies here who are willing to donate their brains, we've looked at this as well. We've actually been one of the leading sites that's sort of a champion of putting this data out there. We've seen the same thing. This doesn't include vascular disease, but only a third of our patients have, when they go to autopsy, have Alzheimer's disease as the only pathology. We see other pathologies, something called TDP-43, which is used to be thought to be associated with just frontotemporal dementia, but it turns out it's associated with this other condition called late, which is a terrible name for a condition because it's an acronym that I'm not even going to say because it's such a long-winded acronym, but basically something that also affects memory and thinking. And then alpha-synuclein is something that we traditionally associate with Parkinson's disease, but often co-occurs with Alzheimer's disease. And one thing I'll point out is at Penn, and this is based on autopsies and brain donation from our cohort, TDP-43, alpha-synuclein, and the tau of Alzheimer's disease were all described here at Penn through my predecessor, John Trojanowski. And so Penn has played a really key role in defining these different conditions over time, and the field would be nowhere without that definition. And it actually is a tribute to the people who are willing to donate from our community. Co-pathologies matter. They are a source of the heterogeneity we see. I mentioned earlier, you saw some people had really rapid decline in their measures and others that were really flat. Well, one of the causes is this co-pathology. So this is just one example looking at that TDP-43. When it's in people with Alzheimer's disease, the rate of atrophy in the memory area of their brain, shrinkage of that, is much faster in those with TDP-43 than those without it. And so it really influences outcomes. Again, I think we've hammered this home. The diagnosis of Alzheimer's clinically is limited. We're about right 75-80% of the time. And that incorrect diagnosis, we used to say, well, clinically it doesn't really matter because there's not a therapy and it's almost always some other degenerative condition. And so, we treat people symptomatically. It's not going to make a big difference. But one area where it really made a big difference is in clinical trials, because if 25% of the people in your trial don't have the disease you're treating, it's going to be really hard to see a treatment effect of the drug because many of the people in the treatment group aren't going to respond because they don't really have the disease. The other thing is because we're moving towards directed therapeutics, the misdiagnosis obviously then has even more implications. And again, the main pathologies of Alzheimer's are these amyloid plaques and tangles, and that really is what defines Alzheimer's. If a pathologist looks at a brain, that's what they are defining the disease as having. And as Sanjeev mentioned earlier, and this is actually a direct picture from my other predecessor, Chris Clark, who led the Penn Memory Center, this is work showing with amyloid PET that there's a very high correlation between amyloid PET imaging and the amyloid plaques of Alzheimer's disease. And there are now 4 FDA-approved tracers. They're not covered by insurance at this point, so we only get these through research. That very likely will change with some of these newer drugs that are coming out, because we need to know about people's amyloid status. And now, remarkably, there's even ways for us to measure that other protein in Alzheimer's disease, tau, with tracers. And again, the same kinds of studies were done that link what we see in a patient's brain on a scan to what we see in pathology. And so this tool is also very useful. There's one already FDA approved for this. And in fact, in the donanemab trial, they tried to find a sweet spot of how much tau there should be in the brain for treatment effects to be as efficacious. And I think there'll be other tracers approved in the near future. And so this has led to something we talk a lot about in our field, which is, should we biologically define the disease? Should we define the disease based on amyloid and tau the same way that a pathologist defines the disease based on amyloid and tau? And I think the general feeling is we should, because that's what we're trying to treat, and that's what the biology is directed at. And so that led to something called the ATN framework. Jason Karlowicz was on this initial paper describing the ATN framework. And there we determine the presence of amyloid. That can be determined by amyloid PET or spinal fluid. And then we determine the presence of tau based on tau PET and another spinal fluid measure of phospho-tau. And in order for us to say someone has Alzheimer's disease, one needs to have both amyloid and tau in their brain. And then N reflects neurodegeneration. That's the downstream effects of these molecules in the brain. And that helps us with staging the disease and determining to the degree to which that's actually affecting someone. And just very briefly, one thing we've done, and I won't go into detail, is because we know tau and brain structure, that the injury to the brain in Alzheimer's is really driven by tau. One of the things we've been trying to do with imaging is to determine how much of the injury to the brain is due to Alzheimer's disease, and then what's left after, to measure how much other factors in the brain are causing people's memory or thinking issues, and also whether there are people who are resilient, who have less brain shrinkage than they should for a given level of Alzheimer's disease. And actually we've had really great success in seeing that we have people who are vulnerable, who likely do have other co-pathologies and have a more rapid rate of decline. And then there are people who have resilience and have very little to no decline over time. Why is this important? Why would we want to bring this into practice? Well, I don't know, if we're going to treat someone with donanemab and there's a risk to it, maybe we think, if you're looking like you're not going to change a lot over the next 4 years, maybe we wait. Maybe if you're going to be more rapid, we're more aggressive about trying to treat earlier. And so these are the kinds of things that we're going to start needing to bring into practice. But as Sanjeev said earlier, blood tests have arrived too that might make things a little less expensive to do. There are blood tests for the amyloid in the brain. These are about 85-90% accurate relative to PET scans. So not perfect, but if nothing else, they incredibly speed up the time studies can be done. So if we're doing a study, again, like the AHEAD study, I think someone raised their hand, or a couple people raised their hands who's in that. If we're looking for people who have quote-unquote preclinical disease, don't yet have symptoms, instead of scanning 5,000 people right away, one can get these blood tests in 10 or 15,000 people very quickly and find people who are likely to go on to have a positive amyloid scan. And it really shortens the time needed for a trial. And actually it really reduces the expense of the trial as well. There are also tau measures now that Sanjeev mentioned that might be even a little better than the amyloid measures. I put this in because this is work that includes people in the ABC study. So these are controls from our ABC study, or cognitively normal individuals who are amyloid negative, and these are people with autopsy-confirmed Alzheimer's disease, and there's really big discrimination on these blood tests. They really do what they're supposed to do. And there are other newer blood tests that are coming out that even have higher accuracies, almost up to 95-96% of detection of the disease. So these are here, and they're going to be brought into practice, no doubt about it. And then there's these trials, and I know we did our video before, and so I won't go into detail, but they're really remarkable. I think, again, imperfect, but from the sense of moving forward in the field, I think really amazing that there are these drugs that are directed towards the amyloid in the brain and actually really truly reduce the amyloid in the brain. So this is amyloid PET using the drug lecanemab, and this is on placebo with amyloid PET, so these patients continue to have very high levels of amyloid and actually go up a little. And with lecanemab, there's an incredible reduction in amyloid in the brain, and in fact, about 70% of people by the end of the study are what we would call amyloid negative. You would get an amyloid PET scan, and you wouldn't know that they had Alzheimer's disease based on the amyloid PET scan. And we see that also affects tau in the brain, this sort of downstream effect of amyloid the same thing, where they have much lower levels as opposed to increasing. All that doesn't matter a lick if it doesn't change cognitive trajectories in people. It's a laboratory experiment until it does. And the reality is it does seem to slow down the disease modestly, though, not dramatically. Maybe, depending on the measure you use, about a 30% slowing of the disease for this drug. We don't know, these drugs have only been studied for 18 months, though, and so we don't know they've been studied longer, but the data that's come out has only been for 18 months. And so we don't know 2, 3, 4 years if those curves continue to separate, if they move together, if they cross. We don't know. And so that's what we'll have to learn clinically. The bottom line is this study, its earlier study, now the donanemab study, there are multiple studies showing this clinical effect with the drugs that are potent like this particular drug. And so I think monoclonal antibodies are going to come into our clinical practice. I think that there'll likely be FDA approval for lecanemab, full approval by July, which will then influence Medicare decision-making around coverage, which right now it's not covered. Donanemab showed, at least based on a press release, maybe even more impressive results, in part because they used precision medicine. They really defined individuals based on how severe their Alzheimer's disease was, using amyloid and tau PET imaging. But they met all of their endpoints as well. That was very similar to their earlier study. They quoted that after a year, 47% of people on that drug remained stable relative to 29% on placebo. So the drugs seemed to work, and it would have actually been very disconcerting if donanemab, quite frankly, didn't work, because it would be hard to then understand why lecanemab did, and even the signal that we saw with aducanumab as well. So I think we now know that if you clear amyloid, it does affect outcomes in individuals. However, and again, I don't want to get into this in too much detail now, but we'll continue to give public lectures. There are risks and that weigh those benefits, and we're going to have really significant conversations with people about what their risk tolerance is and how they want to think about this drug. But I think we all believe that should be a discussion between us and a patient, rather than something that people don't have access to. I'll just say, and I have only 2 slides yet. I know I'm probably like 30 minutes over, so I'm sorry. But I'm so excited. We're not done, right? So these drugs maybe slow the disease down 30 or 40%. Why is it only 30 or 40%? Well, one might be that amyloid's not enough. 2, it might be those co-pathologies we're talking about. It might be that if you treat Alzheimer's, you're only treating Alzheimer's, and that maybe the maximum you can get isn't 100%, maybe it's 70%, 60%. Bottom line is that we're looking at other pathways, and there was recently also just extremely exciting data about trying to tackle that tau protein in the brain as well, using a genetic approach, something called antisense oligonucleotides, which is basically where you try to block mRNA, the genetic code that then produces tau in the brain. And using that, there was really convincing reduction of tau in the brain measured by spinal fluid, but also measured by tau PET. And so I think that's really exciting, because it might be that dual therapy with something like this and an amyloid therapy might be most effective. But even more than that, because of increases in funding and attention to this disease, as well as our successes, there are many, many trials in the pipeline, many studies, and I think maybe we benefited a little bit from some of the earlier failures with amyloid, because it really pushed the field to look at other mechanisms, things like inflammation, lipid stuff, some of the things we've talking about with genetics, just brain aging in general. And so there are just a panoply of drugs that are in various phases of trials that are directed towards different mechanisms that may actually, again, be different from one patient to another. The other thing I'll say is there still are, and we still are very much interested in, drugs that treat people who are symptomatic, because we need to think about not only just slowing down the disease, but treating some of the symptoms of the disease. And I think that sometimes gets a little lost from people like myself actually giving talks like this, that treating behavior, treating mood, all of those things are things that we are woefully limited at and need to get better at. So I think these therapies are going to require a precision medicine approach. I mentioned donanemab, which required a particular level on your tau PET that showed an effect. There almost certainly is going to be people who respond well to these drugs, and there are going to be people who don't respond well to them. There might be people who respond super well to them, and I think it's incumbent on us as a research center to study that, because ultimately we want to learn who's going to best benefit from this drug, who's not going to benefit, and that will help with risk-benefit analyses. And so we are, as a center, and I think the Alzheimer's Disease Center program across the country is very committed to learning that. And we're going to have to integrate, I think, a little bit more how we do clinical practice with research, and actually learn from all of you as we treat patients or as you participate in our research studies. And my hope is that, and there's actually some literature on this, that within medicine there's this cascade effect where when new therapies come out, it accelerates additional therapies down the future. And that was probably most actually strongly seen within HIV with the very initial therapies. AZT was not actually a highly effective drug, but it really spurred on a number of other drugs, and then combination therapy became used, and actually it's really changed that disease's course for individuals, and incredibly, I mean, it's one of the great accomplishments of medicine over the last 40 years. So this is why we at the ADRC, in the ABC study, D squared, LEADS, et cetera, why we study all of you who participate so much, is that we want a precision medicine approach where we collect genomic data, comorbidities, social and structural determinants of health. We try to link this to what we're seeing in the brain, and the only way we can see things in the brain while people are living is through, I always offer this, if anyone wants to give us a piece of their brain, there's a sign-up list in the back for that right now. We measure that through all of the imaging and tests we do. And so while we ask a lot of all of you, that having all of that data in individuals actually really helps us link together the biology of the disease, and I think is what's needed moving forward. So with that, I will end, and thank you all for your attention, and thank you all for being wonderful partners with us.